various different approaches to the frontline lymphoma, perhaps follicular lymphoma, perhaps using an anthracycline type of regimen in patients that have more aggressive disease, that you either demonstrated transformation or suspected transformation, some of that high PET avidity, perhaps single agent monotherapy in follicular lymphoma in the less fit, or even in patients maybe less bulky, and then bendamustine rituximab for a lot. Does that line up with the way you think about things, Pierluigi?
Absolutely. I'm using bendamustine plus rituximab from 2015, and I'm very happy because it's possible to have a very good result in terms of clinical response when you compare with CHOP, R or CVPR, but at the same time it's less toxic. It's very important for the patient to avoid, for example, nausea, vomiting, and in particular alopecia. I use CHOP plus rituximab in a selected patient, for example, grade 3A, or in a young patient with a real important tumor burden, but no more than 10% of patients are treated with CHOP plus rituximab. I don't use CVP plus rituximab. Anyway, in the Gallium study, the arm including CVP plus obinutuzumab was quite interesting. It was the best in terms of improvement of CR rate and overall response rate, was the best when you compare with the bendamustine plus obinutuzumab or CHOP plus obinutuzumab. Anyway, BR is the most used chemoimmunotherapy regimen in Europe, in particular in Italy, in Germany, in Nordic countries, and also in Spain.
What about post-treatment evaluation after chemotherapy? We talked a little bit about PET scanning before. What about PET scanning afterwards, John?
Yeah, I think PET scanning afterwards is really, again, as I even mentioned earlier, it's the gold standard really to assess the response at the end of treatment. Again, it's simply because it's much more sensitive and much more specific than a CT scan. It's not required. We recognize that there are advantages to it, but certainly we recognize that there's costs, and for some patients it may not be warranted. But in general, I would say a PET scan at the end of treatment is the standard of what we're doing now.
Matt, what if they're PET positive? Are you doing something different in that setting?
Well, it depends upon how PET positive they are, and I think our radiologists have started to adopt kind of the more contemporary Lugano criteria and applying it to follicular lymphoma with a Deauville score at the end. And if you remembering back to the response rates that are CT based, a lot of patients with follicular lymphoma will have a PR. So now we're taking a lot of these people with PET-based therapies, and they're a metabolic CR, but they have residual, abnormal nodal size. So it's kind of new territory in regards to that, to know what to do with it, because on one hand, it's an incurable disease, right? But on the other hand, if their delta SUV, isn't something that is impressing you but it still goes from 6 centimeters down to 1.8 centimeter, but the SUV stays at 8. That's a tough to know what to do with.
Yeah, and I think also I just jump in and say it depends on where that lymph node or that lesion is, because there may be some that we'll zap it with a little radiation and clearing that up, and it won't be a big deal, not a lot of morbidity, and that might actually be very beneficial to that type of patient. I guess the other question though is, do you actually go and do maintenance therapy as a way to continue to consolidate the remission or improve the remission if you see some remaining PET avidity? And I actually don't use that typically to say if I'm going to do maintenance therapy or not. I'd be curious if other people do, but it's probably not a driver for if I'm going to do more of that or not.
Before we get to the maintenance question, because I think it's a long discussion, but that you brought up a really interesting point. So that person has an SUV of 8 afterwards. And perhaps giving it radiation. I guess I worry that that's different biologically than the rest, and do we need to biopsy that?
Right, and I think that's the inherent question is what is kind of, you do a PET, how soon do you do it after chemotherapy? If it's an SUV that's kind of hovering around liver background, that's different for me than if it's 2 to 3 times liver background and an abnormal lymph node, or it really didn't move but everything else moved. To me, that's a different biology, and that's probably the biology that's going to get that follicular lymphoma patient into trouble in what would be the near future.